Good evening, everyone. How are you all? Brilliant. So welcome to First Aid AMC Clinical free 2-week sessions again. So please make sure that this is not MCQ class. There is MCQ class also going on at the moment, but it's in a separate Zoom session. So if any of you are here who is thinking this is a MCQ class, please go to First Aid AMC MCQ and you'll see that there is a Zoom ID and a password given there. So if you join using that Zoom ID and password, you'll be able to listen to our ongoing MCQ session. Okay. It should have just started, so you can still go and catch on. Okay. So AMC Clinical, right? So we did discuss a little bit about AMC Clinical preparation. We had a couple of sessions, and mostly those were psychiatry. So we did a psychiatry theory class, and we discussed about MSc, and you did really good in our last session with the role play class. So tonight we are going to discuss a new topic, which is cardiology. Very exciting, and it's one of the most important topic for AMC Clinical Medicine chapter. So as you remember from our first session that in AMC Clinical Examination, you can get like mainly we said 2 questions from gynae obstetrics. You can get 2 questions from psychiatry. You can get 2 questions from 4 questions from pediatrics and 4 questions from physical examination, mainly 3 to 4. And rest of it will be a combination. So medicine has like mostly 5, 6 questions. So it's really important. So again, if you have missed what I have said, so gynae and obstetrics, you get 2 questions. And then for pediatrics, more like definitely 2, but it can increase to 3 to 4. Physical exam 3 to 4. Then we have meds and surgery, rest of it. So, and also psychiatry, sorry. So psychiatry, you get 2 questions. So you can understand that lots of questions come from medicine surgery, okay? So 4 to 5 or even sometimes 6 questions. So medicine and pediatrics has the highest number of cages. Like usually that's what we prepare you for. And there are lots of questions in these two subjects. So most important, medicine has a huge amount of questions, and then pediatrics. Apart from that, psychiatry, gynae ops has some very limited questions. Pediatric and physical examination has a huge amount, which we discuss anyway. So when we discuss about medicine, we divide medicine into different chapters. So like we do cardiology separately, respiratory system, GIT, genitourinary or renal system in that way. And then at the end of the cluster-wise approach, we start as a random cages. So cluster-wise approach is one of the most smartest way to prepare for AMC clinical. If you know that how to concise your preparation, let's say within one history format, if you can finish at least 6 to 7 cages, it becomes so easy to remember these cages. So that's what we do in our course. We make the clusters and we give you the same format of history, physical examination, and then just the management is different. So you'll see that how the cluster-wise approach makes sense for your clinical preparation today. So I hope you guys got a bit of understanding about clinical preparation, but again, it's too early to become pro. So you'll need at least couple of months to become a pro prepare. Like you will no longer be a beginners. Then you will become a bit pro, and you will understand a lot of things about clinical preparation. So right now, most of you are still beginners, and that's totally fine. And within couple of months, like you will be able to know everything that you really need to do. So first, tonight we are going to start with Syncope cluster, and then we will give you some idea that how, just by doing a single history format, how you can cover 6-7 cases using the same questions, using the same physical examination format. So that will make a lot of sense, I hope. We discussed a lot of things about clinical preparation in our last couple of sessions. And let's not go with that discussion tonight. Let's focus on cardiology and then we can move forward. If you have any questions, just like other classes, write it on our chat box. I will be able to answer. And at the end of the class, we will discuss a little bit about the new course if you have any questions. Okay? So you can hear me well, no problem so far? Brilliant. Moving on to syncope. So syncope means loss of consciousness, or we can say sudden loss of consciousness in a patient. So whenever a patient comes to you with a history of syncope or sudden loss of consciousness, what should be our differential diagnosis? So the initial 2-minute time that you get to read the case and also get to know what are the tasks in this case, that 2-minute time, as soon as you finish reading the task and the question, your first thing is to remember the differential diagnosis for that case, because that's going to help you a lot during history asking. And if your history goes well, the case will go well. If your history is not good, you will not end up getting even the diagnosis right. So differential diagnosis for every cluster is super important. You need to memorize at least some of this cluster like syncope, at least 10 differential diagnoses you should just remember straight away. Some of the cluster, maybe 5 or 6 differential will do, but syncope, palpitation, these are highly important cluster. And for this kind of cluster, more differential diagnosis will be needed. So when we talk about sudden loss of consciousness, the two systems that comes in our mind is cardiovascular and central nervous system. And then there are some miscellaneous. So CVS related can be sudden loss of consciousness can be a finding of even myocardial infarction or ischemic heart disease. It could be any kind of arrhythmia like atrial fibrillation, SVT, ventricular fibrillation, any of those. Could be valvular heart disease, which will include aortic stenosis or HSCM, which is hypertrophic obstructive cardiomyopathy. Prolonged QT syndrome, it's a part of arrhythmia, but there is a case comes in exam, which is about prolonged QT syndrome. So that's why I kept it separate so that you don't forget. So these are the CVS related causes: arrhythmia, aortic stenosis, HUCM, MI, and prolonged QT. Then we have got CNS causes. So CNS causes can include transient ischemic attack or stroke, head injury, infection, epilepsy. So any kind of cardiovascular, any kind of CNS differential diagnosis, if you want to remember, the easiest way is just to remember by trauma, tumor, infection, stroke, epilepsy. So these 5 will cover everything. So if you just write trauma, tumor, infection, stroke, epilepsy. Okay, so trauma is not very important, but we can ask for, like, especially to rule out any head injury. Tumor, yes, a patient who has a brain tumor can come to us with loss of consciousness. Infection, such as meningitis, encephalitis. Stroke, definitely important cause, and E for epilepsy. So any of those, trauma, tumor, infection, stroke, and epilepsy, that will come under CNS differential. And then the others, it can be vasovagal, postural hypotension can come as syncope, hypoglycemic attack, even anemia, which is severe anemia, can come with loss of consciousness. Some medication, unlikely that it will cause loss of consciousness, but you can remember it. And even sometimes it could be severe stress or psychogenic. Okay, so these are all the differential diagnoses of syncope cluster. And if I tell you that what are the important cages under this cluster, so that will be aortic stenosis, myocardial infarction, prolonged QT syndrome, vasovagal syncope, postural hypotension, super important, hypoglycemia. So all of this comes in exam. So you can understand the importance of this cluster, right? So moving on to history taking. So using this same history, we are going to cover everything. So let's have a look. When we come with so what will happen? They will give you a patient, like a 50-year-old patient comes to you with a sudden onset of loss of consciousness. Then the task will be, so take history from the patient. The second task is usually ask for physical examination findings from the examiner. The third task will be explain diagnosis and differential diagnosis to the patient. And the fourth task can be management sometimes. In face-to-face exam, management usually not super important. Whereas in online examination, management is usually present in almost every cases. But still, you should know the full thing. So let's say we are talking about history first. So if you remember in our first trial class, we discussed how this works. So 2 minutes, you get to see the question on a monitor outside the room. And after 2 minutes, there is a bell. Then you go in, and examiner stand in front of each of the station. Examiner will first ask your ID that you hang around your neck. Examiner will check that, yes, you are the right person for this station. And then they will introduce you to the patient. So let's say that examiner says, well, this is your patient, Sam. You can start. Then you thank the examiner, and then you go into the room. And sometimes you might stand, or sometimes you sit in a table or chair. So when you go in, you get to see the role player. So what will you do next? This is a sudden onset loss of consciousness patient. So first of all, hi Sam, this is Dr. Arshan. I'm one of the doctor in this emergency department. So always know from the STEM whether this is a GP setting or it is an emergency department setting, because management might differ based on where exactly the patient is. So you can get a patient who is presenting to a GP clinic or in a hospital setting like emergency. So if it is an emergency department, so what will you say? So I'm one of the doctor in this emergency department. It's very nice to meet you. Sam, I can understand from the note that you had a sudden loss of consciousness. Is that right? Yes, doctor. Well, that must be very scary for you. How are you feeling now? Patient say, I'm feeling fine now. Well, that's really good to know. But because you had a sudden loss of consciousness, I just need to make sure that you are vitally stable. So I'm going to talk to my examiner and come back to you. So you take a permission from the patient, then you look towards the examiner who will be also in that station, and you'll say, dear examiner, I would like to know if my patient vitally stable for further history. So in here, examiner can give few response. Examiner can say, yes, you can proceed. Examiner can ask, what do you want to know? Or examiner can say, go to the task. So if examiners say, yes, proceed, that means patient is vitally stable. If examiners say skip or go to the task, it means examiner doesn't want to give you the vital at the moment. If examiner asks, what do you want to know? It means he wants to know that what vitals you're looking for in this patient. So for a patient who has sudden loss of consciousness, you want to know the blood pressure and pulse. That's the most important two vital. So you will say to the examiner, I would like to know the blood pressure, both standing and sitting position, and also pulse with rate and rhythm. There is a reason for it because postural hypotension is one of your differential diagnoses. That's why we are asking blood pressure in both standing and sitting. Our differential is arrhythmia. So we want to know the pulse rate and rhythm both. Okay. Not every case will need you to ask both rate and rhythm or both standing and sitting BP. Depends on if it is relevant. In this case, it is relevant. Make sense? So, so there are several responses that you can get from the examiner. So any sudden or any acute history or any acute presentation, you will need to make sure that patient is vitally stable before you can ask any history from the patient. Once you made sure that this patient is vitally stable, you will thank the examiner and you will go back to the patient. So normally there is a chair which rotates. So you can just rotate towards the examiner when you ask the vital and then thank the examiner and rotate back to the patient. Then you say, thank you so much for waiting, Sam. Now, would you please tell me a little bit more about this sudden loss of consciousness? So we always start with the presenting complaints, or I normally say HOPC, which is history of presenting complaint. Now, in HOPC, the first thing is always an open-ended question. So can you please tell me a little bit more about what exactly happened? Did it make sense for everyone, like how to start? Yep, good. So now we know that how to start a case, and most of the cases, the initial starting will be like this. And if you just know one starting, you can use the same starting for any history taking. Okay? Now, this is a syncope case. In syncope, we divide the history of presenting complaint into three parts. So we try to find out what happened before syncope, so pre-syncope, what happened during syncope, and what happened after syncope. So pre-syncope, we ask, can you tell me a little bit more about what exactly happened? Then the patient usually will give us some kind of information that, yes, I was doing this, that. So patient usually give us some kind of information that I was like, maybe they say that I was just playing tennis with my partner and then suddenly I lost my consciousness. So get an idea that what happened. Now, based on what information we don't get from the patient, we will need to ask it. Like if patient did not say when that happened, we will say when exactly that happened. If patient did not say what they were doing during this thing happened, we want to know what were you doing at that time. So it just depends that whatever patient will not give to you, you will need to find that out. And any kind of history, we always need to know when this happened and what exactly were you doing when that happened, right? So that's a must to ask questions. Once we have asked that, is it for the first time? If patients say no, we need to find out how many episodes so far. Can you describe me few of the recent episodes? What were you doing that time? How, like what happened after that? So give me some idea about the recent couple of episodes. Let's say patients say, no, this is for the first time this happened. Then we can go to the next question, like, did you fall suddenly or did you feel any lightheadedness or dizziness? Why we ask this question? It's a very important question because if it is a sudden syncope, it goes more towards cardiogenic syncope. If patient had a prodromal symptom, like they had lightheadedness and dizziness, that goes with some others like vasovagal syncope, sometimes neurogenic syncope, those ones. So sudden syncope always goes to cardiogenic. Then we can ask any headache, any blurring of vision, any weakness anywhere in your body. Now, this is mainly for CNS related causes. So you are also asking some of the differential diagnosis right now. So CNS cause mainly stroke or any transient ischemic attack. Patient would have blurry vision. They might have even weakness in some part of the body. So pre-syncope questions will be like that. Again, if this is not the first time, don't forget to ask about the previous episode because it gives a lot of idea. So definitely ask how many times so far. When was the first time this start? Do you think you're getting these episodes more frequently? Can you describe what were you doing during the recent 2 episodes? How long were you unconscious during that time? Did you need to go to hospital at any time? So get some very detailed idea about any previous episodes if they have. So that's pre-syncope questions. In the syncope questions, was there any witness? Because when patient lose consciousness, they will not know what happened. So if there is a witness, they can actually give us some information. So was there any witness? Patient say, yes, my partner was there. So did your partner say that you lost your consciousness fully? Yes. How long you lost your consciousness? Did your partner notice that you had any jerking movement of your body? Did you wet yourself or lose a stool? Did you bite your tongue? By any chance, did you injure your head when you fell? Very important to rule out any head injury. So jerky movement, wet yourself or pass stool, bite the tongue, this is for epilepsy. So right now you can understand that we are ruling out some of the CNS differential, right? So epilepsy is ruled out, head injury ruled out, stroke TIA ruled out. So few things you are ruling out during this HPC anyway. Then post syncope. After you regained your consciousness, how were you? Were you able to stand by yourself or someone needed to help you? Did you feel confused and drowsy afterwards? Because if it is a epilepsy, patient will have a post-ictal confusion. So they might be drowsy or confused even after regaining the consciousness. Whereas if it is a cardiogenic syncope, it is sudden onset of loss of consciousness and also sudden regain of consciousness. So they will have a fall suddenly. They will lose consciousness for, let's say, for 1 or 2 minutes, and then suddenly they will regain consciousness, and there will be no confusion, no drowsiness. So sudden syncope and sudden regain of consciousness, that's how cardiogenic syncope looks like. And any weakness, any problem with your vision or your speech, that's also to rule out any stroke or TIA. So that will give your a detailed history of the presenting complaint. So find out what happened before losing consciousness, find out what happened during syncope, and what happened after regaining the consciousness. Okay. So far, good, everyone, with the HOPC. At the moment, patient is not unconscious. So he had an episode of loss of consciousness. Now he is definitely conscious. Otherwise, he would not be able to come to you, right? Yes, that's right, Dr. Somoy. So apart from those 3 to 4 physical examination station, all others are this kind of a station, history taking and everything. Okay. Once we ask the history of presenting complaint, we go to the differential diagnosis question. So we have severe CNS. So for cardiovascular, ask any chest pain, any shortness of breath, any racing of your heart. That covers almost everything. So chest pain, shortness of breath will be found in MI or ischemic heart disease. If it is a aortic stenosis, also comes in the same way. Chest pain, shortness of breath, and syncope. And arrhythmia will come as racing of the heart. CNS, we already asked a lot. Even we asked about head injury. So if you forgot to ask head injury during that time, you can ask it now. And we just did not ask the infection question. So any fever, rash, any neck stiffness. So that covers our severe CNS DD. Next is the others. So first, for hypoglycemia, by any chance, did you skip your meal today? So many times what happens that patient might just skip their breakfast or lunch and they went for some unusual exertional activity. Their blood sugar can fall and can end up having a loss of consciousness. So that's a hypoglycemia. Hypoglycemia doesn't necessarily has to happen in a diabetic patient always. A normal person, if they do a lot of exertional activity in a hot, sunny weather and they did not have their breakfast, lunch, they can even end up losing their consciousness, right? So don't just assume that just because patient is not diabetic, they can't be hypoglycemic. A lot of doctors has this idea that it has to be a diabetic patient. It's not always the case. Next, vasovagal. Vasovagal syncope is a very common syncope. Even it's one of the commonest syncope presentation in the hospital or general practice. So vasovagal syncope is normally we say that some patients, if they are, let's say someone is running a marathon or someone is working in a hot sunny weather and they haven't even like they haven't even drank any water or even any food, they have been just working for hours and hours in a very hot weather, or they're playing sports. Suddenly what can happen that their vagal nerve can get stimulated, and vagal nerve causes peripheral vasodilation, and that will cause pooling of blood in their lower extremity. So the blood goes to the lower extremity, brain doesn't get enough blood or oxygen, and patient end up losing consciousness. So that's vasovagal syncope. There are not lots of questions that we can ask, but we can say that when this happened, was it a very hot, sunny day? What like were you doing a lot of physical activities on that day? So you can ask the circumstance of that day when this happened. Especially, was it a hot, sunny day? Were you doing a lot of exertional activities during that day? So that will be vasovagal syncope. Next is postural hypotension. Postural hypotension happens in elderly patient who change their position. So when their blood pressure drops, when they change their position, let's say someone's blood pressure when they are sitting is 140 by 80, and then when they stand up, it falls to 110 by 70. So we say that if systolic blood pressure falls more than 20 or diastolic falls more than 10, when they change their position, so it can be changing position from lying to sitting or sitting to standing. So that's called postural hypotension. And it happens in patients, especially elderly, who are on lots of volume depleting medication, like lots of blood pressure medications, diuretics. They can actually end up getting this kind of postural hypotension. So the question that we ask that do you feel dizzy or lightheaded? when you get up from the bed in the morning. So when they get up from the bed in the morning, they need to change position. And if they say that, yes, I feel very dizzy when I change position, you can think of postural hypotension. As you can see, for each differential, we are just asking one question. If any time we get any positive finding, then we ask a little bit more detailed questions to find out what's really happened. Okay? Like for postural hypotension, there are lots of other questions that we can ask. But in here, we would not ask it unless we find something positive, because you don't have that much time in the exam. For anemia, do you feel tired and fatigued these days? For stress, give some confidentiality. Say that I'm going to ask you about your home and work situation, but please be aware these are confidential. So how is your work and home? Is there any stress? Then ask about any other, how is your general health, any past medical conditions such as diabetes, high blood pressure, or any heart condition? Do you smoke or drink alcohol? Are you on any medication? Any family history of any heart condition? Any family history of any sudden death due to heart-related condition? So sudden cardiac death usually common in patient who has HOCM. So HOCM or HOCM, they usually give this kind of history that someone in the family died in very young age and it was very sudden. So HOCM, even aortic stenosis sometimes can have sudden cardiac death, or even sometimes prolonged QT. So prolonged QT syndrome can have this kind of history as well in the family. So these are your differential diagnosis questions. So if we go back to our DD, so we can see, so we asked CVS CNS question, then we asked vasovagal, postural, hypoglycemia, anemia, and stress. Okay. So the format of any history taking is like that. First, introduce. If it is an acute case, make sure patient is vitally stable. Then ask the history of presenting complaint. Then rule out all the differential diagnoses one by one. And then finish with SADMA, which is a smoking, alcohol, medication, past medical history, family history. That's what you should remember. That's the step-by-step format. You should not start. So a lot of candidate, what they do, they ask the HOPC, they forget all the differential diagnosis, and they start asking these questions because this is easy to ask. But your differential diagnosis is the most important thing in a history-taking case. Okay? So don't forget the differential. Clear everyone about the history? So if there was no witness, then you can still ask some questions like how long were you unconscious if you have any rough idea. By any chance, when you regain consciousness, you notice that you have soiled yourself or wet yourself. So it just like the way of asking questions will be different in that case. Yes, so you can fail the whole case if you give the wrong diagnosis. That's right. Okay. Now, once history is done, you will thank the patient and then you'll say, now I'm going to talk to my examiner and I'll come back to you after that. So then you go towards the examiner. So you just rotate your chair towards the examiner. And your second task is ask physical examination finding from examiner. In face-to-face exam, this is a must to do task. So most of the questions will have this task, which was not there in online examination. In online exam, they usually provide a physical examination card. You don't need to ask it from examiner. But in face-to-face, you have to ask it. And the things that you ask, that is the only thing that will be given to you. You will not get any other findings unless you ask so. So that becomes a bit tricky. If you don't ask a specific physical examination, they, even though like there is finding there, the examiner will not give that finding to you. So how to ask physical examination finding from examiner? So normally you would not ask more than 2 physical examination finding at a time. So you can't just ask to the examiner that, examiner, I would like to know the general appearance, vitals, BMI, neck, and CVS examination. You can't do that. So there is a specific way to ask it. So you'll say, dear examiner, I would like to do physical examination on my patient. How is his general appearance? Does he look distressed or comfortable? So everything you have to ask. So does he look comfortable or in distress? Pickled. Pickled is part of general examination. So pickled means pallor, icterus, which is jaundice, cyanosis, clubbing, although it's C, but we just write clubbing as K, lymph node, edema, dehydration. So you don't need to ask all of them. You just need to ask the relevant one. For this case, you know that pallor is important because anemia is one of your differential. Others like icterus, cyanosis, clubbing, not super important for you. You can always ask edema, dehydration everywhere, but depends. So I would like to know the general appearance. Is he comfortable or in distress? So examiner will say he looks comfortable. I would like to know, is there any pallor, any sign of edema or dehydration? So you can ask 3 max, but not more than 3. Negative. So examiner will say negative. How about the vitals like pulse, blood pressure, oxygen saturation? So examiner will give you the finding. How about the temperature? So when vitals, it is mainly blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So you can ask 3 and then these 2. So I would like to know the vitals, blood pressure, pulse rate, and respiratory rate, please. How about the temperature and oxygen saturation? How about the BMI? BMI is not needed for every case. Like for cardiac case, BMI is important because that's one of the risk factor. So we usually ask the BMI for cardiovascular cases. Then I would like to do a neck examination. I would like to know if there is any raised JVP or any carotid bruit. I will do full body systemic examination, but my focus will be on cardiovascular system. So the focused examination, you will need to ask the detail of it. In here, cardiovascular is your main systemic exam. So you'll say, on inspection, any visible cardiac impulse. On palpation, is the apex beat normal in position? Examiner will say yes. Any palpable thrill, any parasternal hip? No. How about auscultation? Apart from S1 and S2, is there any added sound like murmur? Examiner says no. Then I would like to do a complete central nervous system examination, including the both upper limb, lower limb, and cranial nerve examination. Examiner might say everything is normal. I would like to finish with all other systemic exam, including respiratory and abdominal exam. Is there any office test available, like urine dipstick, blood sugar, and ECG? Now, office test includes only few tests. Office test is something that you can do in the bedside. So bedside test, you can ask those finding of bedside test from the physical examination from examiner. Now, even though we know sometimes we can do a chest X-ray as a bedside test, that is not usually part of office test, in your AMC exam. So for office test, it's always relevant office test. Is urine dipstick very important in this case? Not really. So if you don't ask it, it will be fine. But blood sugar is very important because hypoglycemia is one of your DD. ECG is important because you have an entire CVS differential diagnosis. So you'll say, is there any office test available such as blood sugar or ECG? The office test that we have is urine TP BSL, ECG. We have urine pregnancy test. We could ask spirometry sometimes. Okay, so that's pretty much the one that we can do as an office test. Sometimes if it is a warfarin patient, we can get the INR as well, which is not usually an exam case. So ideally, anything which can be done as a bedside test, that is office test. Okay? Does it make sense? It might be a bit tricky. I will actually discuss how to do this fully. And Dr. MC, we already discussed about it. So in face-to-face, when we started this case in the history, we already said that yes, we will have to ask about the vitals. You can't just do it immediately before starting the station. That's very rude because what will happen? They will just fail you straight away. You have to introduce yourself first to the patient, take excuse from the patient, and then ask it from examiner. You can't directly ask it from examiner without talking to the patient first. In face-to-face, can't we simply observe if the role player is demonstrating sign of distress? Do we have to ask from the examiner? It's just a general appearance. So we can see it, but when we do the physical examination, it's a part of physical examination is the general appearance of the patient. It is physical examination, it's not an observation. So it's important to understand that you can't observe whether a patient has a raised JVP. You can't observe whether a patient has a carotid bruit. So observation is not a part of physical exam. Okay. So that's why examiner give you the finding because these patients are simulatory patient. They don't have the findings. So every time you ask for a finding, they will give it to you. And that's how it works in exam. If you don't ask a particular finding, they will not give it to you. Okay. It takes time. That's why the management is usually not a task in face-to-face exam because they know that it takes time. Whereas in online exam, if any of you prepared for online exam, they the only thing is after history taking, they could give you a physical examination finding card. And that saves at least sometimes 1.5 minutes or 2 minutes. So they include a lot of management in that exam. Whereas in face-to-face exam, when the exam will start, you will see that like there is not much of a management case because they know that it takes a lot of time and no one can do history, physical examination, diagnosis, explanation, and management. It's also important to know that it's not always that you have to ask it. There are like in between your 14 station or 16 station, you will find out that two or three stations, they will provide you a physical examination card. But most of the other station, you will need to ask. Yes, so there are two kind of case where one case is like this, where you take history, you ask physical examination, finding from examiner, and then there are another case, which is a solely physical examination case, where you don't take history. You do the physical examination on a person in the exam, and you find the finding. So there are two different physical examination for exam. One is this one where you ask the finding, you don't do it on a person, and examiner give you the finding. Another one, which is just a physical examination station, that's a station you'll need to do it on a patient. That means you need to do a physical examination on a patient. There is no history taking, nothing, just physical examination. Okay? So if I'm going to do this case in exam, like if I need to ask physical examination from examiner, I will start like this. So dear examiner, I would like to do a physical examination on my patient. First, on general appearance, does he look comfortable or in distress? Any pallor, any icterus, any sign of dehydration? How about the vitals? I would like to know blood pressure, pulse, and respiratory rate. How about temperature and saturation? On neck examination, any raised JVP or carotid bruit? I would like to do full cardiovascular exam. On inspection, any visible cardiac impulse. On palpation, is the apex bit normal in position? Any palpable thrill or parasternal hip? On auscultation, apart from S1, S2, is there any added sound like murmur? I would like to do a full central nervous system exam, including cranial nerves. And also, I would like to finish with all other systemic exam. Examiner, is there any office test available, such as blood sugar or ECG? So every time I'm stopping, examiner will give me a finding. Okay. If I miss something, they will not give it to me. Make sense now? So once examination is done, so once examiner give you the finding, you will thank the examiner, and then you go back to the patient, and then you explain the diagnosis to the patient. Okay, now when we will do the physical examination class, then we will talk about physical examination, how that works. Okay, because otherwise you will just mix everything. Let's move on with the history format for today. Do we have to examine ourselves or just ask? So for this case, you just ask. So you ask it, and examiner give that finding. You don't need to examine for yourself for this kind of case. There are cases where you need to do it. Okay, first case. Now that you know the history and physical examination format, we will utilize the same history, same physical examination for any case that we are going to do today. Okay. So first one is aortic stenosis. You are a GP, and your next patient is a 52 years old male who is consulting about a recent loss of consciousness. Your task is like this: focused history from patient, physical examination from examiner. Now, investigation, it depends. They always say, like, they always give you the full question. So they will say, ask investigation from examiner, and give your diagnosis and management to your patient. So they always say that from where, or like you will definitely ask history from the patient always. Physical examination from examiner also always. Investigations depend. So they can say that explain what investigations you will do to the patient, or they can say ask investigations from examiner, and examiner will give you the finding. So in cardiovascular case, if this is a task, ask investigation from examiner, what is the most important investigation for cardiovascular system? ECG, that's right. So they actually want you to ask an ECG from the examiner. So if you say, dear examiner, I would like to order an ECG for my patient, then they provide the ECG on this on you. So there will be a paper ECG. You will need to read the ECG and explain that ECG to the examiner sometimes. So we'll talk about it. Then diagnosis and management. So the positive points in this case was patient was playing tennis and started to black out. Now remember one thing, positive points will not be given in the exam like this on a card. When you ask those history, just like how we have shown you, throughout your history taking, you will find these kind of findings there. So they can give you any finding, but let's say that this is how it is. Patient was playing tennis, started to black out. He is also having exertional dyspnea for the last 2 months, and sometimes he gets chest tightness or pain. So the triad of aortic stenosis is shortness of breath on exertion, chest tightness plus syncope. So that's all that you have got here. Along with that, because this is a valvular heart disease, any valvular heart disease will give you a murmur. So that will confirm the diagnosis when you do it, when you get the finding from the physical examination. So in the physical examination from examiner, they will give you this finding that there is a ejection systolic murmur in the aortic area radiating to the neck. Sometimes they might not give you everything. So you ask the examiner that apart from S1, S2, is there any added sound like murmur? Examiner can just say, yes, there is a murmur. That's it. They would not say which kind of and anything. You can ask. So you can say that, well, I would like to know, is it a systolic or diastolic murmur? So that's the time it will show to the examiner that you know about murmur, right? So is it systolic or diastolic? Let's say it is systolic. So we know that there are two kinds of systolic murmur. One is ejection systolic and another is pansystolic. So then you ask, is it a ejection systolic murmur or pansystolic murmur? Examiner say it's a ejection systolic murmur. So then you can ask that, I would like to know the site of the murmur. So then say it is on the aortic area. Then you know that it is a aortic stenosis murmur, because aortic stenosis murmur is the ejection systolic murmur. To confirm, you can also ask that, is there any radiation? An examiner can say, yes, there is a radiation to the neck or carotid. So they don't always do that. If you are running out of time, the examiner will not bother to waste a lot of time. But if you have enough time, they can just ask these questions in this way. Okay? So examiners are quite understandable in the exam. If you're running out of time, sometimes they help you to go to the next task. Like many does, many don't. So if you're lucky, you can get a good examiner. Okay? So that's why it is also important to have a basic idea about some of the common murmur. So you should definitely know that ejection systolic murmur for aortic stenosis, pansystolic murmur for mitral regurgitation. Then we have like aortic regurgitation murmur, which is early diastolic, right? So we should know mitral stenosis is mid diastolic. So these are very common murmurs, especially aortic and mitral murmur. So you should just memorize this murmur just for the sake of examination. So once you know that, yes, this is a aortic stenosis case, you can easily come to the diagnosis based on the history and the murmur finding, right? Then your explanation. So you'll say that from history, now what you have done, that your physical examination is done. You thanked the examiner and you came back and now you're explaining to the patient. So you'll say, thank you so much, Sam, for waiting. From history and physical examination, most likely you are having a condition called aortic stenosis. Because every one of you who is preparing for AMC clinical, they think that you are the junior doctor and you are actually joining the hospital as a RMO or a junior hospital doctor, right? Or junior house officer, JHO, RMO, is those things. So as a junior doctor in a hospital, you are not supposed to say that, yes, this is the diagnosis, because you haven't confirmed the diagnosis yet. You need to confirm. And the only way to confirm an aortic stenosis is to do an echocardiogram. So without doing an echo, you can't just say you have got a condition called aortic stenosis, because that means you are sure. A cardiologist can say that, but as a junior doctor, you are not supposed to mention that, yes, you have got this. You can always say like that, that from history and examination, it seems like that most likely you have got a condition called aortic stenosis. And that's the way to explain. If you seem very confident in the exam that you don't need to even consult your senior or even your cardiac register, you will fail the case. The exam is not about how much knowledgeable you are. It is more about, do you understand your limitations? As a junior doctor, you have a limitation, which is that you can't manage a aortic stenosis patient by yourself. You'll need to involve your senior register. You'll need to involve a cardiologist, and they are the one who is going to manage this patient. Your job is to make the diagnosis and include or inform the register or inform the specialist. If you don't understand that, even in the exam, you will fail all the cases. And that's where most of the specialists, because many of you are a specialist in your country, you fail the case because you think that you can manage this patient by yourself. But exam actually doesn't want you to be a specialist. They want you to be a junior doctor because that's why you are preparing and that's the position that you are going to work. Like most of you are going to work. Okay. Many of you can work as a registrar, but most of you are going for RMO. Okay. So in exam, it's must that every management that a junior doctor does, they involve a, a registrar or they involve a senior because that's a protocol. Okay. So if you remember, I told that there is a pen and paper in front of every case. So after you say that, yes, most likely you have got aortic stenosis, you need to draw something. So drawing a particular disease is very easy to explain and patient understand it very easily. You can't use medical jargon for this exam. If anyone use a lot of medical jargon, they can fail the exam because of it. Because you're talking to a layman or a non-medical person. They don't understand, like, they don't understand what is valve. They don't understand what is endocardium. So if you use a medical term, you need to explain that medical term. And best is to avoid a lot of medical term. So your explanation should be in a layman term, as simple as possible. They don't care about if you're talking a pathophysiology to a patient because patient doesn't care about it. If a patient understands why I am losing consciousness, that's what they will feel more understanding, or that's what they want to know, that why I'm suddenly losing consciousness when I play tennis. And your job is to explain that, not the pathophysiology of a valvular heart disease. Okay? So you'll say that, let me draw a picture for your better understanding. So let's assume this is your heart. Our heart has 4 chambers. Each of these chambers has a door-like structure known as valve. In your case, the valve that controls the flow of blood from the heart to the aorta. So this is the aorta, and this is aortic valve. So in your case, the valve that control the flow of blood from your heart to the aorta, known as aortic valve, is narrowed. Okay, so without drawing the picture, is it possible to explain this to anyone? Really no, because no one will be able to understand it. So that's where drawing picture comes. So you don't need to be a very good like artist. As long as they can understand what you're trying to say, that's fine. So you'll say that this is our heart. Heart has 4 chambers. Each of the chamber has a door-like structure known as valve. In your case, the valve that controls the flow of blood from the heart to the aorta, known as aortic valve, is narrowed. And this is what we call as aortic stenosis. This is why the blood supply, so because this aorta carries blood to everywhere in our body, including the brain. Because the aorta is not getting enough blood supply, your brain is also not getting enough blood supply. And sometimes when you do something exertional, such as playing tennis, it causes more reduction of oxygen flow to your brain. And that's why you are losing the consciousness. So you can explain in here like this. So that is why the blood supply to the brain is being reduced, causing the loss of consciousness. And when you exercise, the demand of oxygen gets increased, but it is already narrow. So it can't supply enough blood and oxygen, which gives you the chest pain and shortness of breath as well. So correlating the patient's symptom with the patient's condition is the way to go. when your explanation inform a patient that why I'm getting short of breath, why I'm getting chest pain, why I'm losing consciousness, that matters a lot rather than giving a pathophysiology of a condition. So it's for whole, like throughout your life when you'll be working in Australia, try to make sure that, try to explain the patient's symptom, not a general explanation. It's all about what a patient is feeling. And if you can explain why they are feeling in this way, they will really love it. Okay? So after an explanation like this, you always need to say that, are you understanding me? Are you with me so far? So always make sure patient is understanding you. Now, after explanation of a condition, the next thing is management. So if you are in the emergency department, you will just admit this patient to the hospital. If you are in a GP setting, you will need to send this patient to the hospital for further diagnosis. So let's say that you are in the emergency department. So you will say that, are you with me so far? Are you understanding me? Yes, doctor. Well, as part of further management, now many times this is where after your explanation, you might need to explain some of the differential diagnosis. So if your task is to explain diagnosis and DD, then after explanation of the condition, you're supposed to say what are the differential diagnoses in this case. Even if the task doesn't ask you to talk about differential, if you think that you have done well, you are not running out of time, you can still say some of the differential, even the task is not DD. So like very quickly you can say that, are you with me so far? Yes. Well, it could be due to other condition as well. Like it could be a heart attack, but you don't have any ECG changes related to that. It could be some brain-related conditions such as a stroke, but you don't have any weakness, then you don't have any head injury history. It could be some other condition like vasovagal, but your condition doesn't have anything to do with exertional activities, if that is the case. So whenever we say the differential, we just need to explain why this is not the diagnosis. So let's say in this case, there is no management, which most of the time will be in the exam. Your task is explain the condition to the patient and give differential diagnosis. Once you explain the condition, your differential diagnosis should be more detailed. Like you will say like this, you could have other condition as well, such as it could be heart attack, but you don't have any chest pain at the moment. Your ECG doesn't go with heart attack. It could be some other arrhythmia or heart rhythm disturbance, but you don't have any racing of the heart at the moment. It could be some nervous system related condition, but like you could have a stroke, you don't have any weakness, any blurring of vision or any speech problem. So it is unlikely. Could be head injury, but you don't have any history like that. It could be infection in the brain, but you don't have any fever, rash, neck stiffness. Could be epilepsy, like you don't have any seizure or any fit history. It could be postural hypotension, where blood pressure drops when a patient changes their position, but you don't have such history. Could be anemia, but during your examination, we didn't find any pallor, and you also don't feel quite tired these days. So these are all very unlikely. See that when differential diagnosis is the task, then we go too much, a bit detailed about all these differential diagnoses that we asked. And we one by one, we say that why we don't think this is the diagnosis. Okay? Does it make sense to everyone? Now, let's say that differential is not a task. Your task is diagnosis and management. So as part of the management, you'll say that as part of the management, I would like to admit you to the hospital for further investigation and management. First, I'm going to talk to my senior who will come and review you, and also a cardiologist, like a heart specialist, will come and see you. In the meantime, I'm going to take some blood for necessary investigation, such as full blood count. We will do some inflammatory marker. If ECG hasn't been done, we will organize another ECG. We'll check your liver and kidney function. And most importantly, a cardiologist might want to do an echocardiogram of the heart, which is nothing but an ultrasound scan of the heart, which can confirm which valve has got narrowed and how much narrowing it is. Based on the echocardiogram report, if the aortic valve is significantly narrowed, then the management is usually surgical, and the surgical management is a valve replacement. If the valve narrowing is mild to moderate, then you will be just managed as a conservative treatment, which is wait and watch, and also preventing any other cardiovascular risk factor. But this will be discussed in detail by your cardiologist. Once you're stable and we know the management, then the specialist will be happy to discharge you back home, and you will be reviewed by your general practitioner. I'll give you some reading materials about everything I discussed, but feel free to ask me anytime if you have any questions. Do you have any questions right now? Okay, so this is how we explain the management. So now I know that it is a bit tricky when we start doing all of this with you, but let me explain what I have done. So forget about this 10-minute break. So first, during our management, the first thing is, what is the condition? So condition is aortic stenosis. Then what is the clinical feature of this condition? Which is your, like, the explanation of this condition, right? Then is it a common or uncommon condition? Is there any complication of this condition? Now, many times, this is not must to do, but condition and clinical feature is really important. So that's what we have done. Aortic stenosis is the condition, and we talked about the clinical features along with the pathophysiology, right? So once you have mentioned that, the next thing is, if we have some time, mention the differential diagnosis. And then we come to the management. First, management will include whether you can manage it in a GP setting, or you need to send the patient to hospital. Second, you need to organize some investigation. You need to also involve your senior or a specialist if it is the emergency department. And then what will be the absolute or definitive management? And that will be done by the specialist. You will say the specialist will do this, that, and everything. So you just give the option. Once you talked about the definitive management, we finish with 4R. 4R include R for red flags. So if you are going to discharge a patient, then you always give red flag. Now this patient is getting admitted, so you don't need to talk about red flag. Red flag is what will bring this patient back to emergency department straight away. Then review. Same, if you're going to discharge a patient, you will usually from the emergency department, you will ask the patient to see their GP. So that's review. Referral. Referral is that if you are in a GP clinic and you need to refer the patient to a specialist or to a hospital, that's under R. And another R is reading materials. So it depends on a lot of factors. If you are going to discharge a patient, or let's say you are in a GP clinic and you are happy to just manage the patient in the GP clinic, then you just give red flags. You talk about when you're going to review the patient again. When you're discharging from a general practice, you don't need to refer, and giving the reading materials. So throughout the case, you will understand what this means. But let's say we just talk about this particular case where patient is in the emergency department and you are admitting this patient to hospital. How you're going to finish the case? Because Finishing is also an art. So finishing should be like this. So you will say that cardiologist will do this. Once the management is done, the specialist will be happy to discharge you back home, and you will be seen by your general practitioner. I'll give you some reading materials. If you have any questions, feel free to ask me. That's the only two R you will use in this case. Okay, no need to talk about red flags because you are not discharging him yet. No need to refer because patient is already in hospital. Does it make sense? So that's how we manage a patient. So we talk about the condition, we talk about the symptoms, we give differential if we can. Then the management includes whether we want to admit the patient, if admission, involve your senior, involve the specialist, talk about the investigation and the definitive management, and finish with relevant 4R. How do we know if we are running out of time? We don't know. It's just a practice. Sometimes with a lot of practice, you will get that idea that when you're running out of time. It's not always Dr. Ang. So most of the time, examiner will give you everything straight away. But sometimes they can bother. So we don't say ESR CRP. See that how I explained, I said full blood examination, liver kidney function, inflammatory marker. So these are all non-medical jargon. We don't say ESR CRP, urea electrolyte creatinine, that we don't do. Okay? Because that becomes a medical jargon at that time. But in Australia, everything that we do for a person, they need to know. We can't just we can't just stick a needle into their arm and take blood, and patient will not know what we are doing. We can't just send the patient to ECG, echocardiogram, and patient will just look at our eyes. So that doesn't happen in here. They know everything. Before we do any kind of test, anything, we need to explain what we are doing and why we are doing. Okay, now we can take a 5-minute break, right? So let's take a 5-minute break and then we'll move on with some other cages related to this cluster. All right, guys, let's start again. So, Dr. Tharindu, if we ask the patient if they understood everything and still they say no, to waste time. It's not usually done in exam. It should not be done. Okay, so they are not supposed to waste your time. So it's very unusual that in AMC, they will just solely want to waste your time. So don't worry about that. Okay, moving on to another case, which is prolonged QT syndrome. So all of these are under the same cluster, and you don't need to know the history or physical examination because we have done it already. A 19-year-old girl comes to the ED because she fell unconscious 2 days ago while she was climbing up a mountain. Your task is same. There is a task of investigation from examiner. So 19-year-old come to the ED because she was unconscious 2 days ago. And the circumstance was climbing up a mountain. So when you ask the history, you will find out that she had 3 episodes so far doing different things each time. She doesn't have any other symptoms except she just lose her consciousness. And this will be sudden loss of consciousness and sudden regaining of consciousness. Okay? No, no other history except there is a family history in the maternal uncle who died of an unknown heart disease. So that's a kind of a clue to think of either it can be a HOCM case or it could be a prolonged QT case. In physical examination, there is no murmur. So no murmur means it is not HOCM, right? So what else it could be? Likely prolonged QT. But you can't just diagnose prolonged QT based on this single history. You need the ECG finding. So when you go to the second task, after physical examination, the third task is asking investigation from examiner, where you will ask for an ECG to the examiner, and examiner will give you this ECG. And then you can diagnose the condition. Now, tonight class is not about ECG discussion because we will do that ECG next class during our palpitation cluster. But just a little bit idea that if you look over here, this is a normal ECG, how it looks like. A normal ECG will have a P wave followed by QRS, and then there is a T wave. We all know about these waves and everything. So what is QT interval? QT interval is the starting of the Q wave and end of T wave. This is what we call as QT. In a normal patient, normal QT interval should be between 8 to 11 small squares. So 8 to 11 small square is usually how we can easily find out in the ECG. So that will be the normal QT interval. Sometimes in the ECG, the paper that they provide you, they can also give you the QTC because in many paper read ECG, all the findings are already given. So you might also notice that what is the QTC? If QTC is more than 400 in men or more than 460 millisecond in women, that means it is prolonged QT as well. So if that is not given, then you just need to measure the number of a smallest square. For prolonged QT or any arrhythmia related ECG, we always look at the long lead. And the long lead is the lead where you can see the full length. All others, you can see lead 1, you can just see up to this. Lead V5, V6, you can see where just a short lead. But this is the long lead, and long lead is usually very useful in arrhythmia. So first look at the long lead. In lead 2, what do you see? You see that there is P wave here, then there is a QRS, and then there is a T wave. So you can see that there is regular rhythm also. So every RR interval is equal. So that means you can rule out atrial fibrillation. You can also see there is a P wave, so definitely not atrial fibrillation. Sometimes we can also measure the heart rate. So we will show you in palpitation class that how to do all of them. But the easiest way is to see that, well, rhythm is normal. Every P wave is followed by a QRS complex. Look at the chest lead for any ST elevation or ST depression. So you will find out there is nothing abnormal in this ECG. When there is nothing abnormal, then normally we look at the QT interval. If you look at the QT in here, so this is the Q, and that's the end of T wave. So this is 5 small square, this is 10 small square, this is 15 small square. So this one is 15 small square, right? That means we know that 8 to 11 small square is normal. So definitely this is a prolonged QT. Okay. In exam, it is also not only just knowing everything, being smart is important. When you know the history, when you know the physical examination, in your head already you have some kind of thinking that, well, this is definitely not a myocardial infarction for a 19-year-old. So it's not, for me, it is not most important to look at the V1, V2, V4, those chest leads. So what else? Patient had a like a family history of sudden death, syncope. I know that there might be a important case of prolonged QT. So why not just check the QT and see what it is? So see that this is how we think in our head, right? And if you do that, you can easily come to the diagnosis within a very short time. Okay. But in a real life scenario, definitely you need to check the full ECG and then find out the diagnosis. But when you're running out of time in exam, then your thinking will help you to make it faster. Does it make sense to everyone? Okay. Now, let's say we found that, yes, this ECG is prolonged QT syndrome. How we are going to explain it? Because this explanation is different, but it is difficult for anyone. So we will say in here that most likely from history and physical exam, and also the ECG, most likely you have got a condition called prolonged QT syndrome. Do you have any idea about it? No, doctor. Well, let me explain. So as you can see that this is the electrocardiogram, or in short, ECG of your heart. And this is nothing but a recording of the electrical activity of the heart. So let me draw a picture. So this is our heart, and heart has electrical activity to pump the blood. So electrical activity will start from here and it goes down to the whole heart, and that helps the heart to do the pumping action. This ECG that we have done, it has different parts representing different component of this electrical activity. In your case, the part that we call QT interval is markedly prolonged, and that is why we call it prolonged QT syndrome. This condition is commonly associated with abnormal heart rhythm, resulting in impaired pumping of blood, which causes this frequent collapse, like in your case. See that we haven't even explained what is QT or anything. We're just saying in a very simple way that ECG has different part, and it represents different components of this electrical activity. In your case, one of the component is called QT, that is elevated. And this is usually associated with impaired pumping action of the blood, because it causes the abnormal heart rhythm. Because the pumping action is impaired, your brain is not getting enough blood supply, and that's why you're getting the frequent collapse. Are you with me so far? Are you understanding me? Yes, doctor. If you have some time, you can give some differential in here. Sometimes this condition can run in the families. Sometimes it can be due to some medication, dehydration, or even salt and water imbalance. Unfortunately, left untreated, this can cause serious consequence. So that's why we will admit you to the hospital. I will involve my senior, and also a heart specialist will come and review you. But please don't get scared. You are in a safe hand, and we'll do our best to manage your condition. So whenever you explain something a bit scary, it's always better to reassure the patient that, well, please don't get scared. You are here with us and you are in safe hand. We will do everything possible to make sure you get better. The specialist might also want to do some investigation, including some blood test and a echocardiogram of the heart. So explain those just like we did. He might also want to start you on a medication called beta blocker, which can help you with this rhythm disturbance. But if that doesn't work, there are several other management that the specialist can do, such as even cardiac pacing, in which they can also make sure the heart rhythm comes back to normal. If all the investigations come normal and we can't find out any cause, then most likely it is congenital QT syndrome, which means it runs in your families. In that case, it will be ideal to ask for your other family members to get a screening ECG. Are you with me so far? I know it is a lot for you, but the cardiologist will come and discuss each and every step of the management. If you have any questions, feel free to ask me as well. I'll give you some reading materials. And also, once you are ready to go to the hospital, ready to be discharged from hospital, we will also write a letter to your GP, and he's going to review you regularly. Okay? So management of prolonged QT syndrome, very unusual to come in exam because you have a lot in here. So history, physical exam, reading the ECG. So they usually don't give management in the exam, but it's just good idea to know. Most of this case will finish at differential diagnosis. Okay. So management, in this case, you will admit the patient, involve the specialist, do the investigation, and management is either beta blocker or sometimes cardiac pacing. And apart from that, if it is a congenital QT, we advise to get like all the family members to get a screening ECG. Yes, so if your explanation is poor, then patient might ask you more questions. But in exam, usually role player does not ask too much question to waste your time. So they don't do it, but if there is something that they don't understand at all, then they can just say pardon me or excuse me. That means that they're just trying to understand it. So if anytime they say pardon me means that they're asking you to repeat it. Okay. Moving on to the next case, postural hypotension. So prolonged QT syndrome is not like a super important case. Maybe once in a while it comes. But postural hypotension is really, really important. So a middle-aged woman comes with dizziness for the last several days. So that's one way. Or it's a 65-year-old man comes to see you because he had a fall yesterday. Take history, physical examination, diagnosis, and DD. So the positive point in this patient was she feels dizzy when standing from sitting or lying position. That alone will give you that this is a postural hypotension. That is not enough. You need to know why this patient getting postural hypertension. So there are several causes. The first cause is polypharmacy. Elderly patient on multiple medications, they are the most likely cause of having this sudden drop. So find out what medication patient is taking, especially if there is lots of blood pressure medication, diuretics, that's the time you would be worried. And many times you might be able to find out that maybe there is a recent addition of another blood pressure medication, or patient might have taken wrong dose. So maybe one medication they have taken twice, okay, or recently a specialist might have increased the dose of one of the blood pressure medication. So in this kind of case, you need to find out that why this patient is getting this. So when you ask about the medication, they will, if it is a polypharmacy case, they will say that I'm on this medication. Don't just stop there. Ask the patient that is there any medication which has been recently added? Who takes care of your medication? By any chance, you might have taken a bit of more dose than prescribed. Okay. So find out what's really happening with the medication. So medication is number one cause of postural hypertension. So polypharmacy. The second is any kind of infection like sepsis. So find out any fever, any flu-like symptoms, anything. Sometimes if a patient has got a lot of diarrhea, vomiting, that can cause this kind of blood pressure drop. So that's important to ask. Sometimes it can be a diabetic patient who has developed diabetic autoneuropathy. They can also get postural hypertension. Maybe this is a patient who has Parkinson's disease. They can also get postural hypertension. Okay. So lots of things that we need to look for in this kind of patient. But most commonly given is the polypharmacy. So first, when you get this finding, you need to find out the cause. So in the cause, we will ask like, so let's say we ask that postural hypotension question. Do you feel dizzy when you change your position, when you get up in the morning? Patient say yes. Then you know that, well, this is a postural hypo case. So then you ask more questions. So any recent fever, nausea, vomiting, any flu-like symptoms, any diarrhea? Okay. So that will cover these questions. And then when you come to the past medical history, ask about any diabetes. If patient is diabetic, then you need to ask a little bit more question about diabetes. So how many years you have been diabetic? Is it well controlled? Have you got any complications from diabetes? We also ask about diabetic autoneuropathy. Diabetic autoneuropathy comes as like indigestion, heartburn, they get diarrhea, they get cramping, bloating abdomen, they get even sometimes blood in the stool, they get sexual dysfunction. So those questions we can ask in these patients if diabetes is positive. If it is not positive, don't bother. Okay. So when you came to the past medical history, you ask the patient, do you have any other medical condition like diabetes, any high blood pressure or any heart condition? Patient say, yes, I have diabetes. Then you'll say, well, so I guess you take metformin for the diabetes? Yes. So how many years you have been diabetic or how long have you been diabetic? How's your blood sugar level normally? Is it well controlled? Yes. So have you got any complications from diabetes? Such as like, do you have any problem with your vision, any tingling numbness in your foot? If not, then find out about the autoneuropathy. So do you get heartburn? Any, do you get bloated easily? Any loose stool? Any blood in your stool? Okay, so just quickly ask it in that case. So that's the only thing that you will need to add in the history for postural hypotension. Apart from that, everything else is same. Once you come to physical examination, you will find out that patient's blood pressure is dropping when they stand up. So they will give you both sitting and standing blood pressure. Okay, so that's the finding. Now there are a few other history we get sometimes. Like one of them was like this: patient was sitting in a church. While standing from sitting position, patient collapsed. So the same scenario. So patient was just sitting and suddenly when she stand, she had a collapse. Another case was patient takes risperidone for psychiatric problem and now coming with dizziness. Risperidone is one of the common medication which can cause significant postural hypotension. So a lot of way a push hypertension can come in your exam. So you need to just be careful that what they're giving to you. So let's say how we are going to explain this. So you'll say most likely from history and physical exam, you have a condition called postural hypertension. Do you know what it is? No, doctor. Well, this is a condition in which there is a sudden drop of blood pressure when you change your position from lying or sitting to the standing position. It could be due to many reasons, like several severe vomiting, diarrhea, high fever, strenuous exercise. But in your case, most likely it is due to the multiple medications you have been taking. So in here, you can also add that because recently you have started taking another blood pressure medication, or recently one of the dose of your blood pressure medication has been increased, that's most likely causing this. Also, as you are diabetic, it could be due to another condition like diabetic autoneuropathy, which manifests as heartburn, bloating, diarrhea, constipation, difficulty in passing urine, or even sexual dysfunction. But your blood sugar is well controlled, so it is less likely. This type of dizziness or fall can be due to lots of other causes as well. So then you can give some DD and say why it is unlikely. As part of the management, I would like to organize some blood tests. So let's say this is in the GP setting. So for GP setting, for this patient, you don't need to send them to the hospital. You will be organizing all the investigation in the GP and then find out the cause and then treat the patient. So first of all, I would like to organize some blood tests, which will include checking your blood count to rule out any drop of your blood cell count, inflammatory marker to rule out any infection, liver and kidney function. We will check your blood sugar and also a ECG of your heart. If everything comes back normal, then we can say that most likely it was due to the medication. In that case, we will consult with your specialist to consider to change or reduce the dose of some of your blood pressure medication. Okay, so that will be the management for this case. There is a case which is like the case with the risperidone side effect. The same thing, you will just explain that it is due to risperidone that's causing this. And in that case, once we order all the blood tests, we will involve a psychiatrist because psychiatrist is the one who can change or review this risperidone. So we will involve a psychiatric team who can either adjust the dose of the medication or they can also change it to something else. In every postural hypertension case, always give some general management. So always say that it's important to take your medication exactly as prescribed. Have a routine to take it at the same time every day. If you forget to take a dose, take it within the next few hours. Otherwise, skip the dose. Do not double the dose. You need to continue taking the medications even if you feel well. Never stop any drug abruptly, but follow this half-minute rule. So half-minute rule, you can use it in every postural hypertension case. When you get up in the morning, sit up slowly and stay seated for 30 seconds. Put the legs over the side of the bed for 30 seconds and slowly get up. And then you can walk. So what we say that from lying to sitting, patient will wait for 30 seconds. And then gradually they will stand and they wait for 30 seconds before they can start walking. In that way, their body will get enough time to recirculate the blood to the brain and they will no longer feel the dizziness when they change the position. Okay, so that's the management for postural hypertension. If it is a medication, it needs to be reviewed, either change or reduce the dose. Okay, basic investigations will be done and 30-second rule at the end. Any questions with postural hypertension, guys? Yeah, so risperidone causes QT prolongation. The clue to the diagnosis will be ECG. That's right. Okay, next case is vasovagal syncope. So as you can see, we're still in the same cluster. Still, we are covering the same history, same physical examination, just the management, which is different. 18-year-old girl fainted during marathon, and it was annual sport. She is now fully recovered, but mother is very worried. History, physical examination tell the possible causes. So it's an 18-year-old who was running a marathon. It was a hot, sunny day, and the girl fainted during running. She also skipped her breakfast, and when we checked her blood sugar, it was 3.6, which is millimole per liter. Less than 4 means hypoglycemia. So sometimes you will find out in one case, there might be multiple diagnoses. And getting all the multiple diagnoses is also important to get a pass mark in that station. So don't just think always that there will be a single diagnosis. There might be multiple as well. Like this case, it was a vasovagal syncope. So you'll say the most likely what your daughter experienced today was a condition called syncope, which is the temporary loss of consciousness. There are many regions which can cause this, but in your daughter case, it could be one that vasovagal syncope, in which, in response to certain triggers, such as overexerting in a hot, sunny weather, can stimulate a nerve in the body, which causes pooling of blood in the legs. And because all the bloods are coming to the legs, the blood supply towards the brain can be temporarily compromised. And that causes this sudden faintness and collapse. Please don't get scared because it is one of the most common cause of fainting and there is nothing to worry about. Another condition that can precipitate this attack is hypoglycemia or low blood sugar, because she did not have her breakfast and then she went for a marathon running. That can definitely lead to a significantly low blood sugar. Also, when we have measured it here, we found that her blood sugar is still low. So we are going to arrange some sugar drink so that she can start getting a little bit more energy back and her blood sugar will come up a little bit more. Now, sometimes in this case, we also find that sometimes they give hard diagnosis, which is iron deficiency anemia. So if it is a girl or any female, don't forget to rule out anemia as a cause of syncope. So anyone between 18 to 55, which is the reproductive age group, in this age group, when a patient comes with, especially when a female comes with loss of consciousness, don't forget to ask about their gynecological history, which will include asking about their period. So you can definitely ask, say that, I'm going to ask about your period history. Is this okay with you? So just ask for a permission and then say, when was your last menstrual period? Do you get it regularly? Any excessive bleeding during period? So some can say excess bleeding or menorrhagia. And excess bleeding during period can cause iron deficiency. And that can be a cause of loss of consciousness because you remember anemia is one of the differential. So that's important to ask. Sometimes even a pregnancy or ectopic pregnancy can be a cause. So that's why asking the last menstrual period is important. Ask about, is there any chance that you can be pregnant? Okay. So that's important to add in a reproductive age female patient. So ask about their last menstrual period. Ask about, is it regular, irregular, and any excessive bleeding. Okay. So that's all about this case. So as you can understand, sometimes one case can have multiple causes. So you need to include all of them in that time. BPPV is not a cause of postural hypotension. Yes, they can give you drug-induced hypoglycemia. Like there is a hypoglycemia case which comes from insulin, but that's a different case. The last case for tonight, and that will be the end of this cluster, recurrent fall. So recurrent fall is a super important, like one of the most important of what we have discussed. So recurrent fall is common in elderly patients. And the same differential diagnosis as we discussed, but we just need to add few things, which is polypharmacy, postural hypotension, CNS CVS like before, vasovagal, some of the endocrine cause such as diabetes, and diabetic complication like hypoglycemia, diabetic retinopathy, neuropathy, electrolyte abnormality, anemia, and we need to always ask about their home situation, their vision and hearing, how is their joint, because these things can cause recurrent fall in elderly patients. Okay, so mostly the same differential, it's just a little bit more addition. So you will start with the same questionnaire. So it's just a fall. So you just ask the patient, can you tell me a little bit more about this fall? So ask all the questions like what happens before fall, during fall, and after fall. Same, it's just pre-syncope, syncope, post-syncope, and we are using this different term, but questions are same. CVS CNS, we know how to ask the postural hypotension question, anemia question, then past medical. There is a case where you get positive diabetic patient. And definitely you need to ask all the diabetic question in that case. So how long you are diabetic? Is it well controlled? Are you regular with your specialist? Do you take any medication? Any problem with your vision? Any numbness, tingling in your legs or in your foot? Ask the whole medication history to rule out polypharmacy. Now, the most important thing is asking the home situation. So who do you live with at home? Do you have enough support? In your home, is there any loose carpet? Any problem with lighting? How's your joint? Any problem with walking or keeping balance? And then smoking alcohol, etc. So the only thing that we added in this particular case is loose carpet, any problem with lighting. Sometimes we also ask that, do you have any stairs at your home? And does this stair have railings? Many stairs in Australia doesn't have railings, and that can be a very risky situation for an elderly patient who is getting fall. So ask about these mechanical causes. So loose carpet, poor lighting, then absence of railings in the stairs. So definitely ask this. Okay. Many of them has very bad arthritis. They can't even walk. So asking about like joint conditions are important. Physical examination is same, but things that we add here is checking the eye, because it's a case where patient is diabetic for a long time and diabetes is uncontrolled. When you get the blood sugar, you might find out it's 26 millimole. So it's very severely uncontrolled diabetes, and that has caused several complications like diabetic neuropathy, diabetic retinopathy. So if it is a diabetic patient coming to you with a recurrent fall, you will need to make sure that you examine their eye, especially check their visual acuity, visual field, and fundoscopy for any diabetic retinopathy sign. And in the central nervous system exam, you say that you do full upper and lower limb neurological exam, including cranial nerve. And when you say, you should also say that I would also check for any sign of diabetic peripheral neuropathy. And then they can say that, yes, there is glove and stocking loss of sensation in the lower leg. Okay. So once you have done that, that's your history and physical exam. And you can see the positive point in here is the patient had 3 episodes of falls so far. He has been diabetic for 10 years. He has numbness, tingling, vision problem. Also has knee joint arthritis. Had a past history of a stroke. Fundoscopy shows retinopathy feature. In physical exam, you have got peripheral neuropathy and blood sugar is definitely high. So your explanation in here would be most likely the cause of your recurrent fall is uncontrolled blood sugar causing peripheral neuropathy and diabetic retinopathy. In this condition, the nerve that supply your lower leg can get affected, and that can cause numbness, tingling. Because you don't know where you are stepping, you can easily fall. So what happens in diabetic neuropathy that especially the sole of the foot, they stops having any kind of sensation there. So think of an elderly patient who can't even know where they're stepping onto. So they can easily fall, right? Also, we have also found some eye changes related to diabetes, which is affecting your vision. So together, these two conditions is most likely contributing to your recurrent fall. Other than that, you have knee joint arthritis, so that can be a factor as well. So that's this case. There is a recurrent fall case, which is due to postural hypotension, and postural hypotension is due to polypharmacy. So it's like finding out one by one. So patient comes to us with recurrent fall, and we found that it is due to postural hypotension. And then we found postural hypotension is due to multiple medications. So it's finding out the root cause, which is important for exam. Okay. And then there is another case like this, which is a complication of diabetes. So what do you think? With a single history and physical exam, we have covered so many cases, and all these cases are very important for your exam. You didn't need to even learn history and physical examination for any of these cases. Using the same format, we could finish everything. We just needed to know the management. Okay? Initially, it can seem difficult, but once you know how to take the history and how to do the physical exam, the understanding the explanation management is not very difficult. Okay? Yeah, there is enough time for all the examinations. So once they don't give you things that you can't finish in time. So there will be enough time, but definitely you need to be quick. If you are not quick, then you can run out of time even in a very short case. Yeah, the recording of the last class was given in the Facebook group. So if you are in our first aid AMC clinical group, then you will be able to find out the recording of the last class. No, online exam, we haven't got any online examination date yet, but there will be some online exam in 2025, but they haven't opened it yet. But that will be very limited. So it will be very difficult to find out or even get into the online exam. So let me see. I think you have a class. So let me check. So yes, so 20th. So tomorrow you are going to have a class with Dr. Cynthia, who is a very brilliant mentor, and she's going to do a random role play session with you. A random role play session is very tricky, and it's difficult initially for everyone. What we make sure that in exam, the cages will come randomly. You would not know that whether the cage is from medicine or pediatrics. So we do these random cages to make sure you are well prepared. And in random case, any questions can come in front of your eyes, and you will just try to do that case. As I say, that it is difficult initially because many of you haven't prepared it fully, but try. Try to do cages, and you will learn a lot from those classes. Okay? How you're going to know about the dates? So date of the classes are given already. So if you go to First Aid AMC Clinical, so so you can see in here, even if you just go to the featured section of the group, you'll be able to see our all the classes schedules. And you can also go down a little bit. So we always keep our classes schedules like that. So there's a lot of post in here you can find out. So tomorrow there is a class, 22nd of January, we'll do the second class on cardio. And then we'll do a cardio role play session. In my view, both online and face-to-face exam is same as part of difficulty. No, nothing, no one is easier than other. Each has their pros and cons. But I would not encourage you to go for online because it will be difficult to get the exam date. So you should prepare for face-to-face if you can. At the moment, this is actually 2 weeks free session, so we don't follow any specific days for it. But the the random role play sessions classes can vary because all of our mentors, including me, we work as a shift-based working. So sometimes class can change, but I always take my classes on the same days, which is Wednesday and Sunday, which will not be changed, but random role play session classes, it depends. Sometimes it can vary, especially the dates. But you will get the classes scheduled beforehand, usually even a month ago. Yes. So you can get visa for exams. So you need to go for a visitor visa. So yes, and like even I had to come. And when I actually appeared the face-to-face exam, I got a visitor visa. So it can be done in that way. And many do this in that same way. And Australia, the visa, the immigration, they know about it. So it's fine. And they usually give it. There should not be any issue with that. Okay. So that's all about tonight's session, guys. If you have any questions regarding the course, feel free to ask me. Otherwise, we'll finish it here tonight. Okay? Yeah, so till 29th January, the classes are free. That's right. All good, everyone. How to enroll for the course? Very good question. So to enroll for the course, so first of all, you can go to our firstaidamc.com. So if you just write firstaidamc.com in Google, so then you will get into our website. And in the website, if you go to 5 months clinical course, so the one way of subscribing is you can just subscribe from here. So if you click on subscribe button, they will take you to your details. Then you click on the next button, then they will take you to the payment page. So that's one way. Or if you want, you can always just send an email to our email address and we can send you the invoice with an online payment link. Okay. So if you have any questions, you can always also send me a message in my messenger. So if you just go to First Aid AMC Clinical, you will see a lot of posts from my end, and you can always just send a message here. Okay. So any of this will work. To know further about the course detail, this has all the course detail written in here. As I discussed in our last session also that our main focus for this year is face-to-face, but when online exam will be opened, we will see that whether there is a lot of online examination. If there is a lot of online examination, we will also give you a good idea about online exam. The course is a 5 months course. The first 2 week sessions are free, which is what we are doing now. And course include everything. So it includes theory as we are doing now. Tomorrow you will see how our role play classes works. And role play classes mainly focus on sample case discussion, which is important for your exam. There is already like hundreds of role play sessions. The video recordings are already available in the portal. So which gives you like a very good idea about how to do role play and what are the important cases for exam. Our focus is physical examination for 1 month, which is really important to pass this exam. There is access to notes until you pass the exam, and there is a recording which is up to 10 months. CPD hours can be added, course completion certificate. So I don't need to explain a lot of things because you know that First Aid AMC Clinical has the highest number of passing candidates in AMC Clinical. So it has that standard that you need to pass this exam, and you don't need to think twice, because we can assure you that with the notes, with the classes, there will be nothing that will be new for the exam. You will be able to pass the exam if you just do role plays, if you just follow what we are discussing. Okay, but definitely there is a lot to work on. As you could see last time when we did the role play, that's the standard we look for. So you need to get that standard, and the standard doesn't come within a day. You need to work on it, and at some point you will find out that you are also doing a very good role play, and you are able to understand what we are looking for. You are doing the cases like a pro. Okay, so don't feel overwhelmed. Everyone is in the same pace, and initially it is always stressful. Even the MCQ was stressful, if you remember. So ideally, within a couple of months, you will be able to understand how to prepare, and you will be able to be more faster in your preparation. So initially, it is slow, but eventually you will get the pace. All right, everyone. Thanks for joining today. We'll see you tomorrow again with Dr. Cynthia. Take care. Have a good night. Bye.